Hello, I'm Tom File from Summa Health Medical Group in Akron, Ohio, and it's my pleasure to discuss with you community-acquired pneumonia in patients requiring admission to the hospital. Now, we generally consider the approach to management for patients requiring admission to the hospital based on general ward versus ICU. The most common need for ICU admission is the presence of severe sepsis or need for mechanical ventilation. Now, with respect to patients who are admitted to the ward, the most frequent pathogens are Streptococcus pneumoniae, Mycoplasma pneumoniae, Haemophilus influenzae, Chlamydophila pneumoniae, and Legionella and respiratory viruses. Several recent studies, mostly using molecular diagnostic methods, have demonstrated that approximately 25 to 30% of adults admitted to the hospital for CAP have a monomicrobial infection with a virus. In addition to influenza, other viral causes include parainfluenza, respiratory syncytial virus, adenovirus, metapneumovirus, and rhinovirus. Identification of such cases without bacterial infection can be important for antimicrobial stewardship, since it is unlikely that antibacterial agents will provide benefit and may be associated with harm, such as resistance or adverse events. A procalcitonin level may be useful here, and we have found this to be helpful to reduce unnecessary antibiotic use, since a low procalcitonin level indicates an unlikely presence of systemic bacterial infection. The rate of mixed viral bacterial infection is approximately 20%. Such mixed infections have been found to be associated with more severe CAP and longer hospitalization than CAP caused by bacteria alone. For patients with CAP who require admission to an ICU, Streptococcus pneumoniae is the most common bacterial cause, but Legionella, gram-negative bacilli, Staphylococcus aureus, and influenza are also important. Community-associated MRSA typically produces a necrotizing pneumonia with high morbidity and mortality. Risk factors for CAP due to gram-negative bacilli, including Pseudomonas, include previous antibiotic therapy, recent hospitalization, immunosuppression, and pulmonary comorbidity, such as bronchiectasis or repeated exacerbations of chronic obstructive pulmonary disease that require steroid and/or antibiotic use. I recommend empiric antibiotic therapy directed against Pseudomonas aeruginosa in patients with gram-negative bacilli and gram stain, since such a recommendation will likely cover other gram-negative bacilli, such as Klebsiella pneumoniae. Now, regarding diagnostic evaluation, I recommend diagnostic tests to determine the pathogen for patients admitted to the hospital to include sputum gram stain and culture, blood cultures, urinary antigen tests for Legionella and pneumococcus, and molecular tests of respiratory specimens if available. Testing for a microbial diagnosis is especially important in clinical or epidemiologic settings, suggesting possible infection with an organism that requires treatment different from the standard empiric regimens. These include seasonal influenza, Middle East respiratory syndrome, community-associated MRSA, and tuberculosis. Molecular diagnostic testing for detection of respiratory pathogens have been rapidly evolving and are becoming increasingly available in clinical microbiology laboratories. Many of these tests combine sensitivity, specificity, and rapid turnaround time to allow identification of a pathogen early in the